Good afternoon, everyone, and thank you so much for joining us today for this webinar, The Bridge Between System of Care and Medicaid Transformation, looking at the value proposition. I'm Ann Rodriguez, and I'm the Executive Director of the Eye-to-Eye Center for Integrative Health. This webinar is a partnership between the Eye-to-Eye Center and Benchmarks. We're so pleased to provide this opportunity for you as providers to hear more about system of care guiding principles and how they can assist you in increasing the value of services that you provide. Today, we're so fortunate to have, well, at least two amazing speakers. We're hoping that Deputy Secretary Kinsley can join us. We are hoping that he can join us to kind of set a context for system of care as a part of North Carolina's move to whole person and integrated care. We have Liz Manley. Liz is a national expert on system of care. We're so fortunate to have her today. She's currently a clinical instructor for health and behavioral health policy at the Institute for Implementation and Innovation. This is housed at my alma mater, the University of Maryland, go Terps. Liz oversaw the system of care coordination in New Jersey, where there's been tremendous success in using the principles to keep children with their families and out of higher level placements. We'll wrap up this hour by hearing from the Division of MHIDD SAS Community Mental Health Section Chief, Saarah Waleed, who will give you some guidance on how the state will be using system of care in policy shifts like Medicaid transformation. One little piece of housekeeping, we ask everyone to remain on mute during the webinar, and we invite you to submit questions through the chat on your screen. Because we want to honor the hour time frame, we'll get responses for any questions and send them to you after the webinar, but we'll not be answering the questions during this time. So now, let me then check, has maybe Cody joined us? I don't think so. Let me check. I don't think so. So Liz, why don't we just go directly to you? Thank you.
Good. Sounds good. So I'll share my screen, put up some slides. There we go. So thank you for having me today. It's really a pleasure to join you. My goal today is really to help you understand what a system of care is, what it's done. And just as you know, my intro, I also do a lot of work with other states besides New Jersey these days, across the country, including having done some work in North Carolina. So I'm really pleased to be with you today. So let's just start at the beginning. What is a system of care? It's basically a way of thinking about how we're going to deliver services, what population we're going to serve, what services will be included in the service array. It's a way to organize and think about making sure that we're culturally competent for the places that we're really looking to serve. And it really serves as that infrastructure thoughts about where we're going to put resources and what those resources are going to look like. So in order to truly understand what a system of care is, we have to really think about values and what the values that help us really think about what we want to do and how we want to do it. The system of care values and principles in which New Jersey transformed the way that they thought about children's behavioral health, and we'll get to New Jersey in a second, but really looked at the fact that we wanted to think about the strengths of the individuals we wanted to serve. We wanted unconditional care, which means no eject, no reject type policies in all service array. We wanted to promote independence, both the child and the family, and be able to move towards independence by helping provide the tools that are necessary to get individuals to get there. We wanted families involved, and in order to get them involved, there were things that we really need to think about for them. We needed to be collaborative. We need those services to be cost effective. We needed them to be comprehensive and individualized. They needed to be in the community. They needed to be team-based. So those are a lot of the driving forces of transformation, is that we didn't just say that these things were important, we lived them. In every decision that we made in terms of building the system, we're based on the idea that every decision had to be meet the criteria that it was going to meet these needs and address these particular values. A word about language. Language is incredibly important. And part of the challenge for behavioral health systems is they focus very much on diagnoses. And it's not that I'm saying that diagnoses are not important. In a managed Medicaid system, they're incredibly important. But they are not how we need to approach families. And so systems of care really build the idea of translators, people who don't need to speak diagnosis language to families, but understand how the diagnosis fits into the whole treatment planning process and the care plan for folks moving forward. So some of the language we really moved away from in New Jersey were things like client, cases, consumers. We didn't talk about mom and dad. We really talked about parent and caregivers, recognizing they were not my mom and dad. We moved to treatment interventions, not placements. Really important around the issue of placement versus treatment interventions, in particular when you're serving a child welfare population or juvenile justice population, where the goal is to have that young person put their head on a safe pillow at night. There's a difference between a residential treatment program and a foster home or an environment in which you want that young person to be safe, but they don't need to engage in these treatment interventions, which are really important to understand the clarity around that particular issue. We wanted to engage our young people and recognize that the workforce wasn't responsible for the engagement of young people. That this idea that they weren't motivated, that families were not motivated, that young people were not motivated, really was insignificant. It was our job to provide the tools necessary for the workforce to be able to engage both young people and their families in this new experience. We talk about transition, not closing, because the idea of closing or terminating, even more abruptly, terminating a 13-year-old just seems really incredibly harsh if you think about it. And then missing or runaway, really big difference. When children are missing, people will come together to find them. If a child runs away, if that's how we describe it, no one comes, right? No one comes. No police, no law enforcement, no teachers come. And our philosophy is that if a young person isn't where we think that they should be, where they're scheduled to be, then everyone needs to go find them and find out why they're not there. And that is how we transform the way that we begin to think about young people and families. This is some of the milestones of system of care work. So New Jersey is not the first system that did this work. There's a lot of system of care reforms that have happened across the country. And the goal in the building of the system of care is to understand those lessons learned from all of the work that has come before and to celebrate that work and to continue to move that work forward. In nearly all reports advocating systems changes, children were not getting their needs met in the mental health system. They were generally served in highly restrictive settings. The services were limited outpatient, inpatient type medical type care. And various child serving systems were sharing responsibilities, but they weren't working. It didn't come together. And families were typically blamed, and they weren't involved because of that. They felt their children would be better off being served by the system because they clearly hadn't done what they needed to do. And they really had this very siloed approach in how they really did this work. So in just about every report around systems transformation, I just want to say New Jersey was no different than this. These are all the challenges that we experienced in the beginning of the system of care reforms. Historically, there's been a lack of home and community-based services, deficit-based model. This is this issue of around diagnoses and how we really think about children, how we think about their parents. The poor outcomes are really related to the idea that we don't have the right resources at the right time, at the right duration in place for young people. Cost is a major factor. But when we put the resources in the wrong places, it's very expensive. It costs the state a lot of money. It costs Medicaid a lot of money. It also costs families a lot of money and a lot of lost opportunities, which are really important for us to be attentive to. Rigid financing structures are very expensive in the long run. And we really need to think about administrative inefficiencies and fragmentation. You can have multiple systems doing the same thing and these overlaps, which I'm going to talk about some of that work that we did to really minimize some of those challenges. Okay, so when we talk about systems, we really want to talk about the processes for transformation, right? And how the system is built. But we also want to talk about the structure and how the functions are, but we also want to talk about what the role of the system folks are together, right? So both of those things are important. In other words, we need to think about infrastructure, and we need to think about the quality of the workforce as an example of some of the things that are really important in systems transformation. So effective systems building process includes leadership and anyway, we need to build a relationship within the community and all of the network partners. Everybody who's going to have a stake in this work really needs to have a voice within the context of the work. And some of those voices will be louder than others. We need a strategic focus. What do we want to accomplish, and what is that going to look like? And we want to think about sustainability at the time that we begin to do the work. These are some of the functions that are really necessary for architects to think about around transformation. Now, because you're beginning this work to think about embedded in the managed Medicaid world, you're already thinking about sustainability right from the start, which is really powerful. And where a lot of states get into trouble right from the start is they don't have an end game of what's going to happen when the grant fundings run out, or when the pilot funding runs out, or a particular funding source. And so it's really important to be embedded in the world of sustainable financing, but also the idea that you're putting policies and practices in that are going to be really important in the long term. These are some of the characteristics of system of care reform initiatives, and really important to think about the coordination, not just of what you do, but what does everybody else do who's working with those families, and how do we actually engage those other partners? As an example, the education system or the pediatricians, how do we engage them in this really important conversation? We need to blend resources when necessary. And we need a comprehensive service array, but that service array is going to change over time. And the reason it's going to change over time is because the way that you deliver services will be meaningful. When it's meaningful, you change what is necessary in order for young people to do well. And we have plenty of examples from across the country of what that means. In particular, if you're spending a lot of time and resources on higher intensities of service, like inpatient care, residential care. As you shift the service array, the number of beds you might need goes down. And so that's really important to think about as you're building sustainability. You want to focus on prevention and early intervention whenever possible, and you want to build bridges to those systems that are doing that work already so that you can be a partner to that work. It's really important to have partnerships and collaboration, because if system of care means one thing, it means relationships. You do want to think about the least restrictive settings, but you also want to think about the most appropriate intervention for a child at a particular time. In other words, we don't want children to fail up, and we don't want them to fail down. We want the right service at the right time for the right duration, and we need tools in our tool belt to ensure that that's going to happen. We want our children to be in their families. We want the community to be engaged as part of the solution. And we want to build on the strengths and resiliency of children. Sorry about that. Not sure what happened. So we want frontline practice shifts, right? We want to think about parents and young people as part of the solution. They're part of the team. We want to acknowledge that we are part of the process, the learning process for them, that we bring tools to the table, but so do families, right? So do our young people. We want to build those professional relationships, and we really want the professionals to understand what their role is at the table. Clinicians have the biggest difficulty in the practice shifts within systems of care, not families, not young people. It is clinicians who do. And I know, because I was one of those folks who really had to think about what being part of a system of care meant and what my role became in this new power dynamic around the work. You want one person coordinating care, not multiple systems coordinating care, which is really complicated for states and communities to do, but it really needs to be part of how you're thinking about this work. And it's just really important to think about it. You want one care plan across multiple systems that could include child welfare and juvenile justice, one care plan that's going to drive the work and the service delivery for these young people. Obviously, you want it to be strength-based. I say that because we've already talked about that. I put that in the first slide. But also, you need to think about how to be cultural and linguistic competence. And by that, I mean not just people who speak the same language, but understand the culture in every single home is different, and that young people have a culture of all of their own, that parents are in a different culture, right? So we need to really recognize the cultural diversity components within a family system, but in a community as well as in in the delivery system. So it's just really important to recognize, as someone who ran the service delivery system in New Jersey, which is one of the most diverse states in the country. This can be really complicated work, but really powerful when you get it right. So you want to think about where the workforce is coming from, and you want to think about how do we bring people into the workforce who come from the communities that the young people are coming from as well. Okay. This is how systems change works, right? This is how we transform. This is what it looks like, right? And so we started at policy level, we moved to frontline practice. We have to really engage communities in transformation. The idea that communities are not going to be part of the conversation is just not right. Communities have to be, they must be part of this conversation in order for young people to transform, for families to transform within the context of this work. And the ownership of work within systems of care is really shared. It's like a three-legged stool that everybody needs to be part of the conversation and own part of it. And in order for the solutions to be long-term and invaluable for the life of the family. So system of care is first and foremost, and really important to think about, is a set of values that we really think about where our resources are going to go, the framework in which the delivery system happens. So they need to be family driven and youth guided, home and community based. And we need to keep in context why home and community based. Children heal within the context of family and communities. That's where the best healing happens, where the quickest family healing happens. And so it's just really important to be grounded within the work within families' homes and their communities. We need to be strength-based and use those strengths to help propel families forward. It needs to be individualized. Even twins require different plans. And so you really need to be thinking about how each of these families are going to do well. Generally, that's in a process called care coordination and uses wraparound as its driver to really ensure that there's this focus on the individualized planning for youth and families. We need to recognize trauma, and not just the trauma that young people have experienced, but the trauma that systems put families through, right? The systems itself, multiple systems, multiple avenues in which families have to come in, they already come in bruised and battered when there's not some attention to that front door and how families are welcomed within the context of the helping systems. Commitment to health equity through cultural and linguistic competence is essential in this work. And certainly we want to be connected to the natural helping networks. That includes things like places like YMCAs can be a helping network. It includes family support organizations, support groups. It includes engagement with family at every level that we can engage. And we absolutely need to be data-driven, recognize the quality standards in which we're trying to accomplish, and look towards our outcomes and what is the experience of families for whom we're trying to serve. The core components of systems of care include governance, and governance is generally this external sort of process in which we engage communities, families, our partners in an equal conversation about how things are going, creating a feedback loop so that we know what we're doing well, what we're still struggling with. Youth and families are partners both at the policy level as well as in the planning process for their own experiences. We want to think about a single assessment tool so that we can actually ensure that children are getting what they need, and we can see it across the system rather than in this really haphazard kind of way with different assessment tools being used at different places at different times. With a single point of access, make it easy for families to actually connect and get what they need. No wrong door approaches mean that we're going to talk to each other, and so that if a family arrives, say at a pediatrician's office, that pediatrician is going to know how to connect that family with supports and services that are necessary to take care of their child. Intensive care coordination using wraparound is important. Mobile response and stabilization, which is really not a mobile crisis type model that you might see in the adult world. It is an upstream intervention that allows parents to tell us that they are seeing changes in their child, in which there's a 24-hour face-to-face access to services and supports so that we can address the sense of urgency that families feel. That we have to address the service array and make sure that that what you need is available at the time you need it for the duration that you need it. And certainly the data collection and CQI are really important parts of this whole plan within the context of what a system of care is. So let's talk about New Jersey and New Jersey's transformation. And the way to talk about that really is to think that back in 2000, New Jersey was pretty broken. And I know I was on the ground as a clinician working in residential world, running a partial care program when I know children ended up in the state hospital, out-of-state residential care. Over 365 children were in out-of-state residential care. The child welfare system was one of the worst child welfare systems in the country, and we had just had a young person complete suicide in a detention center, and we were building bigger, stronger detention centers at that time. Pretty sad time in New Jersey. And some pretty smart people came up with the concept paper to think about how to do the work, right? And so we started with children with most complex behavioral health needs, those children in out-of-state residential care, those who are on their way to out-of-state residential care, those who are on their way to the state hospital. All were prioritized for services and supports in their homes, in their communities, starting with wraparound, moving to the availability to mobile response and stabilization, and all types of other services. This is what New Jersey's system of care looks like today. And I'm just going to walk you through it real quick. It looks really confusing. It's not as confusing as it looks. If you look at the box that says contracted systems administrator, that's all parents need to know. It's a 1-877 number. Parent can call 24 hours a day, 7 days a week, ask for help, and we send it. We don't argue. We don't debate. We don't say, oh, I'm sorry, they're not in crisis yet. Parent says, I need help. You send it. And with that help comes a trained team that will work with the family to figure out why they need help on that day, right? And so that's what New Jersey does. Also, it makes available all home and community-based services for all families, regardless of their ability to pay. Really important work. They have community partners, which you call the kayaks, which are these community-based, not community-based organizations, but they're community planning groups, are just part of that feedback loop. So every single box on this particular busy chart is just important in terms of the values of the system of care in New Jersey that says when a family asks for help, when a young person needs help, we send it and we don't ask questions why. Okay, so we set the vision. We set the vision in the concept paper in 2000, and just a little history for folks. The Children's System of Care in New Jersey really started its work in 2001, and really implementing this Children's Initiative concept paper. And then in 2012, there was a real push to bring children with intellectual and developmental disabilities into the system of care. By that time, by 2012, New Jersey had been successful in bringing every child back from residential care back into the state, had expanded service and service array across the state, closed state hospital, closed 9 detention centers, had reduced the daily population on juvenile probation by 70. And we're beginning to see some real shifts and change in the way the behavioral health system was working. And really, parents of children with intellectual and developmental disabilities were not having the same experience. And so the dual diagnosis task force came together with a set of recommendations, and one of them included to bring the children with intellectual and developmental disabilities into the system of care. I was fortunate to be the assistant commissioner when that decision was made, and I went to the system of care actually as part of my mission was to integrate children with intellectual and developmental disabilities to ensure they had great access to services and supports. And the next part of our conversation is really what that was about. So this is really the summary of the Children's Initiative concept paper, which was, like I said, was issued in 2000. I thought it was a brilliant document then. I think it's a brilliant document today because it laid out for us what we needed to do in order for us to be successful. And from there, we were really able to change the way, not only the way that services were delivered, but the way that people thought about those services and thought about what would be helpful for them, the way that families were engaged. It changed all of that. In 2012, my mission was to really kind of do the same thing, but now we had to actually bring a group of families in, a group of providers and partners into work that they were unfamiliar with. And so this is what we did. First thing we said is, why integrate? Well, we're going to integrate because we want to streamline things for families. We don't want families doing this. You have to go there to get some of your services and here to get other parts of your service. We want it to be seamless for families. We wanted to integrate services and supports to recognize that children with intellectual and developmental disabilities may also have a behavioral health need that could be addressed with the behavioral health services. We did not want families to have to jump through hoops to get what they needed in order for them to address the multiple challenges that their child might have. And so we really set up a system in which we could eliminate some of those barriers to care that families would experience. We also eliminated duplicative services like 2 case managers or 2 care managers, one from the world of developmental disabilities and one from the world of the children's system of care. And we made services work so that they were not overlapping in a way that didn't make sense for families. We listened to what our families said, and we tried to implement plans and resources for them that would make sense. So the first question that we had to ask is, what's the same, right? A lot of people will say, well, what's different between children with intellectual and developmental disabilities, children with complex behavioral health needs? I will argue that you want to start with what's the same, right? What's the same is that they're children, youth, and young adults, that they have families, most of them, and that the communication challenges happen for young people who are experiencing some disruption, some anxiety, some challenge some traumatic event, as an example. They already have some team members already in place, right? They go to school, they have a connection to some schools, right? And so the schools are really important. A child protection can be part of a child's life, whether they have a behavioral health need or an intellectual or developmental disability. So they're partners within the context of this work. Same thing with juvenile justice, right? They could be connected to juvenile justice, and we want them as partners, and we want them on our team so that we can work through those challenges together. Medicaid and third-party payers are part of this conversation, and so are pediatricians. There are more partners within this work, but these were where we started of saying that these are the folks that we need to engage in this new conversation around youth with intellectual and developmental disabilities. And then we asked what's different, right? Communication challenges are different. So we might have different tools that we need in our tool belt to address that. Medical challenges, we need to engage the medical community in a more active way. And dental challenges, let's put that there, right, too. Interventions, the interventions might be different. We might need positive behavioral supports, applied behavioral analysis, and more expertise in those areas. The eligibility requirements were different, right? We had to learn to say no to some things that we were not really used to saying no to, but we had to figure out what we were going to do about them. And the individuals who sit around that table are different. or can be different. Community engagement strategies, we needed new ones because this was a population that was underserved in the communities that they lived in. And we needed longer term supports over the long term, not just short term supports. And the payment mechanisms would be a bit different too. So these were all the things that we were challenged with. And we worked to engage families in this culturally competent way by really taking a public health approach. That single point of access was really important, and addressing the cultural and linguistic competence issues. This became even more challenging as we added American Sign Language and a few other, we had to really address a few other specialties within the context of that work. The individualized planning process as a driver to care is just really important to think about. And then always family-driven, youth-guided with focus on community engagement. These were our leadership challenges. We had to set a vision that was both new and was based in our roots. And this was really important for us to both acknowledge what we had already accomplished, but recognize we had new challenges ahead. We had to document that vision so that everybody knew what it was and could move in the same direction as we were. And so we made sure that we put it in every PowerPoint, in every document, and in every discussion that we had with every single one of our partners. And this is really important work. The communication strategies are just really, really important when you're implementing new things. We had budget challenges and how do you pay for the services? That's a whole different story and a different day conversation. The communication strategies, we really need at every single level, who's going to communicate with young people, who's going to communicate with parents, how are we going to communicate with communities, with our partner providers, with our partner agencies at the state level, with Medicaid, all of them. We had to figure out each one of those had a separate communication strategy that we were really attentive to. We identified early adapters, those who wanted to do this work, were engaged in this work, and really could lead the way for us if we gave them tools early. And we had a real focus on workforce development, making sure that the skills across our workforce we put a lot of investment in training the workforce and thinking about what their needs were, creating a feedback loop so we could hear more from them. These are important considerations whenever you're making a change, right? And for us in building a system of care, it was really important that we paid attention to these things. We had to understand the impact of the current system, what worked, what didn't work, what were we still working to fix. As an example, in 2012, we were still fixing some challenges within the residential world and our residential service array. That work could not stop because we were now integrating youth with intellectual and developmental disabilities. We had to do multiple things at the same time. We had to really take into consideration the parent and youth culture, and our parents communicated to us that they believed the challenges of their children with intellectual and developmental disabilities was different than the challenges of parents with youth with complex behavioral health needs. So we put them in the same room, and they concluded at the end of the day, they were all parents. It's really a pretty powerful day. It was a great day. We had to think about provider culture. And that was really important to put our providers in the same room to help people understand that their expertise now also had to be a system of care expertise. It's a different type of expertise that includes this issue of translation, moving away from some of the ideas that mental health providers, as an example, get into challenges around using diagnoses to describe people. That language and culture change had to happen in the IDD world as well. We had to deal with advocates. And by deal with advocates, I mean, we had to retrain them on how to access services and supports, that this was not an adversarial relationship, that we wanted to learn from them, and we wanted to support our families at the highest level as we could. Some of that meant that if we were fighting the advocates, we could not have enough time to get resources to families, which was really a driver. And so we really needed to sort of lay down our arms and be able to talk to each other about what was necessary to get to a place in which families got what they needed, which is one of the drivers that we really put into place right from day one on what was necessary for change. Data is important, and it's a driver on a daily basis to help us understand where we were, where we're going, what else was necessary. And then the challenge of quality within transition, right? So we want to make sure that all of the touch points are connected and that we're connecting the dot as we go along. And then certainly the issue of privacy is necessary to address. Some of our strategies was to build a team of experts, research, read, ask questions, talk to people, and to do that every day. Build a clinical team to provide guidance. So we had experts who sat at our table who helped us, and we helped our experts understand what a system of care was, so that they started to think differently about children's needs and the recommendations that they were making for young people in terms of what services and support should go into place. So they needed to understand who did what and how they did it. We were great partners with Medicaid and helped Medicaid understand what a system of care was. And Medicaid helped us understand what was possible and what was not possible. And more was possible than we thought. So it was pretty powerful. Engagement of partners, communicate with partners, just really important. All kinds of strategies to just engage as many people as you can within the context of this work. Communicate, right? Enhanced communication strategies means more meetings, presentations, engagements, all that kind of stuff, all really important. We put a lot of time and attention to all of the partners that needed to be in our world and on our teams. Share data, share it all, right? It's data. We put it out there in the community as much as we could, as often as we could, to help us understand how we were doing and to get the feedback that's necessary. So those are some of the strategies we used. And then some of the leadership challenges, because leadership is always, one of the biggest challenges within systems reform is, can you hold the leadership team together and keep them all moving in the same direction as you're trying to accomplish as many things as you're trying to accomplish? And uncertainty is really hard. It's hard for all of us. And so how do you hold people together as we're making these rapid changes? And sometimes it takes, encouragement and support and faith. And sometimes it just says, we're going to do it. We're just going to do it. We're going to see how it goes. Understand and communicate the vision means that you have to be embedded in what the vision is. The vision for us was not complicated. We wanted to expand out home and community-based services for children. We wanted our children to stay in their own schools, in their own homes, in their own communities. It wasn't that complicated, but we had to make sure that we stayed grounded in that work on a daily basis when it appeared like some children had some big challenges and we got worried. And so how do we build that team to keep focused on how we're going to get there, what that's going to look like? Be transparent, talk about it right up front. What are the challenges, what works, what doesn't work? Share information. We just put it all out there. And partner with everyone you can partner with within the context of this work. Partner with everyone you can. Ask questions, talk to people, find out how it's going. What do people think about how the work that you're doing is going? What do they think about that? I heard some stuff I did not want to hear. But I heard it and I listened to what the folks had to say. I went into rooms with families as they yelled at me, and then we worked through these challenges. So these were some of the challenges, some of the ideas that we had. We did a thing called Meet the Director, really was Meet the Assistant Commissioner. And that was a monthly community meeting in which I traveled the full state of New Jersey, which is a little smaller than North Carolina, but I went to every part of the state and met with as many people who wanted to show up. Community members, providers, partners, you name it, they could come, and I would do a brief presentation and then take as many questions as they wanted to throw at me. Really important in terms of helping people understand the system and what was working, what wasn't working, what we needed help on, all really important. We did newsletters and frequently asked questions, updates, and provided as much information to the community as we could. We did regulation review and changes as much as we could in an environment that was not friendly to regulatory reforms. But we did get some through. We engaged our licensed partners within this work. We partnered with every state agency that was involved in the work, including the Department of Health and Developmental Disabilities and Child Welfare and Juvenile Justice. And so those are some of the some of the folks that we brought to our table, that we went to their tables first and we talked with them about what we could do together. And we reached across the aisle and we said, we want to be good partners. And that means that we have to carry more of the load than we're willing to do that, if that's what is going to be most helpful to children and families. So this is what we learned. And this was one of the big lessons that we learned early, and that is that a lot of people did not believe that youth with intellectual and developmental disabilities could demonstrate the level of improvement that we believe that they could. And so we really had to prove that with home and community-based services and thinking outside the box, our young people could achieve things that we couldn't dare to dream about at that time. And we learned we were right. Youth with intellectual and developmental disabilities experience trauma and respond to trauma-informed care beautifully. They really do. When we were attentive to it, it's amazing the transformation for a lot of young people. I'm just saying we want them to achieve the highest level of their own potential. Youth engaged with applied behavioral analysis were shown to have fewer admissions to residential interventions. That's just the truth, and that's the data that New Jersey came up with. And there are challenges in the applied behavioral analysis provider pool in putting it together. But when families were engaged in those resources, that those outcomes were powerful. They were not the only outcomes that we found, but they were important within the work that we did. Youth with autism, spectrum disorder within a context of pilot of 1115 Medicaid waiver, also benefit from the behavioral health service array. So not just services that were designed for children with intellectual and developmental disabilities, they did really well because we used high fidelity wraparound, because we used mobile response and stabilization, because we used intensive in-home services that were specifically designed for children with behavioral health challenges. And our young people with autism responded to those services incredibly well. These are other lessons from the field. And these were my lessons, certainly. Set the vision and don't move away from it ever. We're going to keep our children in their homes, their communities, and in their schools. That's it, right? That's what we're going to do. Sometimes we're going to get it right. Sometimes we're going to get it wrong, but we're going to work on that every day. 2, communicate, communicate, communicate. When you're tired of communicating, communicate a little bit more. 3, youth and family voices are the drivers to innovation, and there's no doubt about that. So the things that you think will work when you get feedback from families work better because they tell us how they work better, how we'll do a better job. The building blocks to the system of care work, we know that because we proved it. We proved it in the data and the outcomes. We achieved every single goal that we had set out for ourselves. Community engagement and participation is essential. It's not a program, but a systems transformation. Programs go away, systems transformation stays. And anything and all things are possible. Just look at New Jersey. So my Jersey folks love when I say that. So here's a couple of data points just for your interest. One is New Jersey has one of the lowest suicide rates in the country. We reduced the daily utilization of residential interventions by 65%. New Jersey, there's no children with behavioral health needs who are in any out-of-state residential care. We increased access to care and reduced the overall reliance on inpatient care by over 40% within the first 5 years of system care. Closed the state hospital, closed 1 adult correctional facility, closed 9 juvenile detention centers, increased access to in-home supports for children with intellectual and developmental disabilities by 90% within 18 months. Okay, I know we don't have time for questions, but I do have a ton of references here for you. I'm gonna make sure that you have access to the PowerPoint so you can see the work that we've put together for you. and where some of these things come from. So thank you very much, and thank you for having me. I wish you all well in your next adventures.
Thank you so much, Liz. I just thought that was incredible information. And I hope everybody else sees the context of it and the opportunities that we have in North Carolina as we work on not just Medicaid transformation with care management and the Healthy Opportunities Pilot and integrated care, but also in the moves that we're making to community-based services under the Families First Prevention Services Act, that we have raised the age in the juvenile justice so that we have more opportunities to work with youth and their families. There's just a big wide open door for us right now. And so thank you for sharing your expertise with us. That was just amazing. And so now I want to turn it over. I'm going to open up the mic to Saarah Waleed. Again, she is with the Division of MHIDD-SAS in North Carolina, and she's the chief of the mental health section, and she's going to close it out. Well, she's going to kind of wrap it up for us, and then Karen McLeod is going to close it up.
Thank you so much, Liz. That was a really incredible presentation. And, you have been a real friend of North Carolina. For the last 5 years, you have shared your expertise, your experience, and your enthusiasm for the benefits of the system of care approach within the Medicaid managed care setting with our division, which is the Mental Health, Developmental Disabilities, and Substance Abuse Services. And Eliza sent policy and operational information to us about how they did it, what they did in New Jersey, and the enormous benefits that were realized for New Jersey's children, as you shared with us in this presentation. You've reviewed our ideas, policy drafts. You have applauded us for our successes with high fidelity wraparound and mobile crisis response, and further extending your generosity by taking the time to share your thoughts on the systems of care value proposition. So thank you so much. Very, very, incredible presentation. And I appreciate the opportunity that Benchmarks and I2I Center for Integrative Health have given me to speak about children's behavioral health and systems of care. As we begin whole persons Medicaid managed care, one of the things that I'm most excited about is to see the transformation of the children behavioral health system as we integrate the North Carolina systems of care framework into the Medicaid managed care. The system of care framework is an inclusive set of values, principles, practice elements, and implementation factors. It has been the bedrock of North Carolina's child behavioral health for over 30 years. As our strategic plan, the core elements of system of care include family-driven, youth-guided care, cross-systems collaboration, service coordination, supports and services that are individualized, strength-based, culturally and linguistically responsive, evidence-based or evidence-informed, and of course, community-based. As the department's behavioral health strategic plan states, system of care will continue to be the foundation of our children's behavioral health system. The tenets of system of care align perfectly with the Medicaid managed care design. Now we have the opportunity to marry the system of care elements to a system design that will hold policy, management, and service providers accountable for outcomes and not just intentions. It will incorporate robust care management that will promote coordination both within a complex health medical system and across other systems mandated to care for the same population, which is child welfare, education, juvenile justice, and early childhood systems. And also creates incentives to use and develop community-based options that will prevent children and youth from having to leave their communities and or minimize the time children and youth must be away from their homes and communities. We obviously have ambitious goals for our children's behavioral health system. The concurrent reforms underway in child welfare, education, and juvenile justice provide the fuel that our whole child approach will ignite to create an integrated approach that will allow for effective prevention, early intervention, and intervention strategies. We will have the means to address the complex need of children, youth with the gravest behavioral health concerns. When the system of care framework can be applied in the context of supportive policy development, community-based service expansion, public-private community partnership, and strategic decision-making, a proactive, responsive, resource-enriched, and outcome-driven child behavioral health system will result in children, youth, and their families thriving in their homes and communities. Thank you so much, and it's great to be here, and it's tough work, a lot of work, but very exciting times for us.
Well, I want to thank everybody. This is Karen McLeod. I'm President and CEO of Benchmarks, and we appreciate everybody who joined us today. I want to give a special thanks to Ms. Waleed, as well as to Liz Manley, who graciously shared her insight and experience from another state. So I think most of you who have taken the opportunity to read through the care management manual, provider manual, have seen that system of care is an integrated part of that care management. So it doesn't matter if you're doing children, adults, ID, it doesn't matter what array of services that you're providing. The expectation is that you are going to integrate system of care into your care management model. So the care management model is a big lift in and of itself. It's an integration of physical and behavioral health care, which we've never done before. It's population health care, which we've never done before. All of this under tailored plans, which we've never done before. So there's a huge change that is coming. And part of that is going to be implementing this system of care. System of care has existed in North Carolina. It's tended to exist in pockets. And we've had areas where it has been successful and other areas where it's really struggled. We've also had areas that it was successful, but when the leadership left or the grant money ran out, then it suddenly just petered out over a period of time. One of the things that we really appreciated about what Liz shared today was the infrastructure that needs to be in place to make system of care work. So for any of you who are planning on being a CMA, a care management agency, or any of you who are looking to do the Healthy Opportunities Grant, understanding how to utilize system of care and looking at other states who have been effective in implementing system of care is going to be critical in the development of your care management model. So Benchmarks and Eye to Eye realize how important this is as you are beginning to develop what your care management model will look like. And as a result, we are planning to continue to work together to bring you more information on how system of care and its role of North Carolina's care management plan will play out. But one of the things we'd really welcome from you is input about what information would be particularly helpful for you to understand around system of care. So you had a baseline today from another state of how they made this work, what their infrastructure looked like. And one of the things you heard from Liz over and over is that this is a lot of a relational kind of change that moves system of care. And if you read that care management model that has been put out by the department, it is a lot about relationships and teams and working in the community and building it. If you are able to embrace system of care and its concepts, your ability to lift care management will move a lot more quickly. So let us know what would be helpful, because we're going to continue to work together to get out some additional learning opportunities that we can put together that we think will be helpful for you, but your feedback would be greatly appreciated. So thank you all for the work that you guys do every day to help systems and communities in North Carolina get stronger. We appreciate all that you do. And with that, we're going to wrap up. We will be getting questions out that we can answer back out to you, and we'll be providing those for you. So thank you all, and we hope you all have a great rest of your day. Thanks for joining us.